The House Health Policy Committee will come to order. Would the clerk please take attendance?
Chair VanderWall.
Present.
Representatives Thompson.
Here.
Meerman. Tisdale.
Here.
Bierlein.
Here.
DeBoer.
Here.
Preston.
Here.
Schmaltz. St. Germain.
Here.
Bonek.
Here.
Frisbie. Whitsett. Carter.
Here.
Whitwer.
Here.
Neely.
Here.
Hoskins.
Here.
Foreman.
Here.
Mr. Chair, you have 13 members present. You do have a quorum.
Thank you, Madam Clerk. Representative Bonak moves to adopt the minutes of the January 21 meeting. There being no objection, the motion passes. Today we've got a few votes as well as testimony on one bill. We're going to start with the testimony in House Bill 5249, introduced by Representative Prestin. Representative, if you could make your way to the testimony table. When you're ready, the floor is yours.
Thank you, Chair, members of the committee. This bill stems from my own experience as a paramedic, from countless conversations with folks in my district and the agency that I serve with. One of the major challenges we face in the UP and the rural communities across Michigan is limited access to critical services. Most of our EMS providers are volunteer-based, and state law requires that all ambulances are licensed at their highest licensed level of care, which they must provide 24 hours, 7 days a week. As a result, many choose to operate at the lowest level of licensure, which is basic life support, also known as BLS. From a staffing perspective, BLS can be staffed with an EMT and a medical first responder, relatively straightforward. Limited advanced life support requires an advanced EMT and a standard EMT to operate. ALS, advanced life support, the highest level, needs a paramedic and an EMT, preferably dual medic. The key point here is that this license level applies to the ambulance service itself, not the individual crew members. So the rig is licensed to the level of care that the service is going to provide and can provide 24/7. Services choose their license based on what they can reliably staff around the clock. In rural areas where paramedics are scarce, overcommitting to a higher level of licensure risks gaps in coverage, so many stick with BLS in order to maintain that 24/7 coverage. The core problem this creates is that even when a highly trained paramedic is on the rig, like when I'm serving, or the gentleman that will be testifying will talk about, we're constrained by the vehicle's license, meaning I cannot use my advanced skills. I have to operate at BLS. On a BLS unit, the crew is limited to basic non-invasive care, think primary first aid, oxygen, CPR, splinting, patient-assisted medications. We're allowed, on BLS, we're allowed very minimal invasive procedures. We're allowed epinephrine, we're allowed glucagon in some services. A lot of it has to do with the protocols that are in place in each service. No IVs, limited advanced airways, no cardiac drugs unless you include baby aspirin, as we're allowed to do that on BLS. No other invasive procedures because they all fall outside of BLS, basic life support. As a result, patients, especially up at where I'm serving, rely on our most abundant therapy that we have. It's called diesel therapy, drive fast. With the long transport times that we have and the little interventions that we are able to provide en route, it's a risky drive to the hospital when you're looking at an hour drive with the limitations that are put on you on your service. House Bill 5249 addresses this by creating an adaptive care license for qualifying community-based ambulance services. This license would allow a BLS licensed service, when properly staffed, to operate at a limited ALS level for emergency responses. It draws from existing process for upgrading service levels, but removes renewal limits, recognizing that many rural areas won't see the population growth needed to sustain a full-time higher licensure. To qualify, a service must already be in existence as of 2025, be owned or contracted by a local unit of government as the designated transport agency, and, be owned or contracted by a local unit of government, and use the flexibility only for 911 and emergency response. Approval of an adaptive care license would involve a recommendation from the statewide EMSCC committee, and the professional body under Michigan Department of Health and Human Services, along with oversight from local medical control in the service area that we operate in. We built in these strict guardrails to ensure the bill supports primary responders without creating redundant services that cannibalize each other's territories. This bill is about providing flexibility when a paramedic is available in small EMS services, so patients can receive the best possible care without unnecessary red tape. In rural Michigan, where transport times can stretch an hour or more, this change will mean faster interventions, better outcomes, and fewer high-risk lights and siren runs, ultimately saving lives and improving public safety. I appreciate the opportunity to testify and look forward to any questions.
Thank you, Representative. Representative Thompson.
Thank you, Mr. Chair. So let me get this straight. So you have an ALS, Advanced Life Support license.
I'm a medic, yep.
So because you're a medic. But if you're on a rig that is designated only BLS, even though something could be happening with the patient, that you could jump in and do interventions such as IVs or airway or anything that you could do to get that ball rolling right now and prevent something, you can't do it on that rig. You have to do the drive and wait till they get to the hospital to
Yeah,
do
we are
it?
limited by our BLS protocol. So that rig, because it's licensed to BLS, has to operate under the BLS protocols, no matter who's on the rig.
Wow.
No matter my knowledge. So I can see someone, going hypovolemic, and I cannot start that IV and bring in fluid support.
I did
Airway,
not know
we
that.
are restricted, pretty heavily on airway management. It's like I said, lights and sirens and diesel therapy is our primary use.
Wow, I did not know that. Thank you. Thank you for this legislation, Rep. Preston.
Mm-hmm.
Representative DeBoer.
So the rig that you're in is only at the BLS level, or would they put the rigs now at ALS to be able to accommodate the part-time with having ALS people in it?
This would allow, like for my service, this would allow the gentleman that'll be testifying after me to apply to license his rig to the higher level, which would be limited ALS, or ultimately, ALS, which is what we are shooting for, is 24/7 ALS. But my service covers 1,000 square miles. It's one rig, and it's all volunteers. It's hard to get there. We've been moving in the right direction, but it's very frustrating to all of us that are paramedics that serve on this service to only be able to operate at BLS because of the fact that we're stuck at that, because we cannot offer it 24/7.
So I'm not medical. So a BLS ambulance versus a ALS ambulance, is it just the staff, not the equipment in the ambulance?
No, it's both. It's mostly it's both. It's the staff and the equipment in the ambulance.
Okay.
The difference between BLS and ALS is so profound, it can't be overstated. We're at the full ALS level, we're able to do surgical airways, which is cricothyrotomies. We're able to do advanced airway placements. We're able to sedate, paralyze, and intubate. RSI, there's advanced cardiac drugs, interpreting our own EKGs, STEMI protocols, stroke protocols. The difference between BLS and ALS is so immense, it's hard to explain to the layman.
So if we pass this, then will the ambulance companies all have ALS ambulances so that you can do whatever you want with whatever equipment if you're staffing it?
No, this is a very, I would say, surgical bill for specific agencies that find themselves in the same situation that we're in. One of the reasons why it took so long to craft is because there is a lot of territories that are open to interpretation where this legislation potentially could be weaponized and destabilize certain covering agencies. So we tailored this with help through EMS division at DHS and MOS to try to come up with a bill that saves lives and puts us in a level where we can provide a better level of care without destabilizing other services throughout the state.
I can't imagine the frustration of an hour drive where you could do something to save the person's life and you have to watch it happen.
It's very frustrating. And if you do decide to take that next step, you lose your license and you usually get prosecuted for breaking it. It's a major violation. So yeah, we literally have to sit on our hands. So
Thank you for this.
Representative Bonak.
Thanks for your testimony. Just to clarify, so if you had, and your rig was an ALS, would you have to have somebody that was trained well enough to be able to, let's say, do some of the advanced life care?
So this is the flex. So the if we get the rig licensed to limited ALS, if we only have an EMT and an MFR, medical first responder, on board, those two individuals can only operate at BLS because that's all that they're licensed for their own personal license. Next scenario, I have an EMT on board and say myself. That would allow it, because I'm a paramedic, that would allow the rig, there'll be a locked box in the rig that only ALS responders would be able to open up. And that would be the gateway to the advanced procedures and drugs that would be available to us. IV kits, fluid support, advanced airway placements, and probably a portion of cardiac drugs. So like I said, that ability to level up, and you got to remember, we're getting dispatched. So a lot of times, if we're getting dispatched to somebody that's showing stroke-like symptoms, showing MI, heart attack type symptoms, we're probably going to change our staffing, and one of the paramedics is probably going to respond to the squad room and go to that scene. So it's going to give us the flexibility, like I said, to bring the best level of care that our agency possibly can.
Any other questions? Representative Carter.
Thank you, Mr. Chair, and thank you for your testimony. I had the opportunity to witness someone getting injured in the Keweenaw Peninsula. It stuck with me really strongly because it took a while for the ambulance to get there. You know, internet connectivity, several issues that could have made the situation better. Here's my question to you: ALS versus BLS. If a BLS ambulance had arrived on that scene, and it would have been something that they had to do an emergency surgery, they could not have assisted that person who was injured? Would they have to wait for an ALS to come on board to do an operate? And I see the gentleman shaking his head. Are you understanding what I'm saying?
Yeah. So there's a couple of things. They have to transport immediately. So they've got one of two things. They can call for an ALS intercept, which then extends the response time, because like my service territory where I live, you're talking about half hour, in these conditions today, probably 45 minutes to an hour to respond. Once they get there and assess the situation, then they would call for an ALS intercept, which would then extend it out a half hour. They would be transporting, and we usually meet, intercepts and BLS usually meet at the halfway point. So it compounds everything when you can't bring your highest level of care to the scene.
Follow up, please, Mr. Chair. So you're saying
Absolutely.
that this legislation would alleviate that situation from occurring. Anybody that's been up in the UP know that there's probably about 10 feet of snow up there, which complicates things even more. So, yeah, just this would alleviate that situation, allow EMTs to act on the situation, correct?
This, to my knowledge, this will directly benefit a few services right now. Its availability, and if it's passed, how it's received and used is going to be interesting to watch, because I know that there's a large amount of BLS agencies out there, but there's a limited amount of BLS agencies that can leverage paramedics, because they don't have paramedics within their districts or on their rosters. My service happens to have a large amount of paramedics and advanced EMTs on our roster, so we would be able to immediately take advantage of this. So I really strongly support this due to the fact that this flexibility in licensure on the rig and the ability for the first responder to operate at his level of licensure and his scope is so important, because it changes the outcome for the patient in such a dramatic way.
Thank you, Representative. Just one last question, and you know, we live in, even though I'm in the lower peninsula, live in a very rural area, and we have a lot of rural areas throughout the state, not just northern lower. In the upper peninsula, I'm assuming that in most cases, most counties have maybe one ambulance service that's on the road at a given time, but we're depending a lot on our volunteer firefighters in this bill. I've got to assume, and maybe you can clarify, that this bill would be greatly appreciated by our firefighters, our volunteer departments. Any word from your locals on that?
This is a game changer. It's a force multiplier when you're allowing somebody to use their full licensure in a situation within reason. It's going to lead to better outcomes, and I hope that this lays the groundwork for all of EMS to start to look at response in a more flexible way. Because at the end of the day, when we respond to an incident, no matter who it is, your loved ones, yourselves, I want that agency to bring its best game to that patient. Because when they bring their best game, we're going to have our best outcome, and that emergency room is going to have a better patient handoff.
Perfect. Seeing no other questions, I appreciate it. We'll move on to the next person that would like to testify. They'll be doing it virtually, and it's Josh Thune from, I believe, Mid-County Rescue. Josh?
Hi. My name is Josh Thune. I work as the ambulance director for Mid-County Rescue Squad in Menominee County. I've been in this position for 3 years now. At the time, I was working towards my paramedic license. I got that and decided to work for a BLS agency because of the need in my community. Like Dave said, we're a small area. We serve about 6,000 people. We're licensed at a BLS level, and we serve 9 different municipalities. We have 22 medical providers on our squad, 6 of which are higher level than EMT, so they'd be able to take advantage of this and move to those higher level skills. As of right now, without changing any of the way we staff, this would cover about 60% of our average call time would be covered by someone at a higher level than BLS. Like Dave said, this would reduce the amount of time that it takes to get that higher level of care to people. In our area, because of the distances to hospitals, we're looking at from time of dispatch to time arriving on scene is about 20 minutes. So that's 20 minutes before we even know if we need to get ALS care to that patient. And like Dave said, we can call an intercept, but it's going to take us 20 minutes to get there, and then another however long for the ALS to meet us. And from our area, hospitals are no closer than 17 miles from anywhere in our coverage area and as much as 40 miles away. So you're looking at half-hour to hour-long transports. And our average time from dispatch to arriving at the hospital is over an hour. So we're just looking at being able to get that care faster to people. And I think it's a lost opportunity when, like I said, I've been on calls where it's myself as a paramedic and another paramedic on the ambulance with me, but we're sitting on our hands, and we actually had to call an intercept due to our protocols for a chest pain patient. And it seems like a waste of resources and not taking advantage of everybody's time. And on top of that, it's not just a care perspective as well as a cost savings. We're charged for intercepts. Just this last year, we spent $24,000 in intercepts. We're a nonprofit. We charge our patients minimally. We charge our municipalities to the lowest cost we can, and that would reduce that stress as well. I think that's all I have to say on it. You guys have any questions?
Thank you, Josh. We do Representative Frisbie.
Thank you for your testimony, Josh. Just, do you have an estimate of how often in the past years you would have been able to utilize this opportunity to better serve patients?
So last year, 14% of our calls we called intercepts. So 14% out of 500, about 80 calls last year.
Sure. Okay. And do you think it'll help stimulate even more growth of the education of your staff to be able to do this?
Definitely. Currently we have 4 paramedics and 3 advanced EMTs. I have multiple people that have already said, they do this on their spare time. They're either retired. We do have, disabled vets that work for us too, that are at a BLS EMT level, and they've said that they would move forward with getting their advanced EMT if they could actually use the skills. They're not going to go take that course unless they can use it, though. They're not moving to another area. They're not going to go get a job for a different agency. They're doing this in their community to serve their community.
I see this as a really good bill that addresses a very specific need in super rural areas like yours that doesn't harm anything. It actually improves things. And to Representative Carter's point, it gets people the help they need a lot quicker. So I'll be supportive of this. Thank you.
Any other questions from the committee? Seeing none, Josh, thank you very much for your time this morning and appreciate what you do. We look forward to working with the bill sponsor on these bills, or on this bill. Thank you. We have a few cards to read in on House Bill 5249, not wishing to speak in support. Stephanie Johnson, Michigan Association of Fire Chiefs. Not wishing to speak in support of the bill, Charday Burton, Department of Health and Human Services. In not wishing to speak neutral on the bill, Angela Madden, Michigan Association of Ambulance Services. Thank you. Okay, now we're going to move on to House Bill 4878. And we do have a few cards to read in. Real briefly, I'll read those in, and then we'll go through the rest of the process of not wishing to speak in support of the bill. Ty Feischman, Michigan Medicine. Not wishing to speak in support, Ashley Christian, Henry Ford. Not wishing to speak in support, Chip Faley, Bronson Health. Not wishing to speak in support of the bill, Eric Roth, Michigan Association of Pharmacists. Not wishing to speak in support, Ben Frederick, Memorial Healthcare. Not wishing to speak in support of the bill, Frank Water, Michigan Primary Care Association. Not wishing to speak in support of the bill, Deidre Wilson, McLaren. Not wishing to speak in support, John Shiflin and Sonny Hodgson, Corwell Health. Then we have not wishing to speak opposing the bill, Sonny Cook and Tim Golding, AFP. Not wishing to speak opposing, Graham Filler, Estellas. Not wishing to speak opposing the bill, Rusty Merchant, AbbVie. Not wishing to speak opposing the bill, Allison Blandford, Amigan. Not wishing to speak opposing the bill, Jessica Cruz, Gillen Services or Sciences. Not wishing to speak opposing the bill, Liz Molly, Merck. Not wishing to speak opposing the bill, Beth DeShone, Forward Network, Michigan. Not wishing to speak opposing the bill, Harrison Hem, Public Policy. And not wishing to speak opposing Libby Brunsvin, Vertex, Pharmacists. With that, on House Bill 4878, I want to say to everybody that is here, everybody on the committee, thank you for your words of advice, wisdom. We spent a lot of time, and I really, truly do appreciate the input from each and every one of you. We heard the concern about the reporting mechanism and the transparency piece. So in this substitute, it supports that change that the entity that will do the oversight will be Lara. And that's really the nuts and bolts of that. With that, Representative Tisdale moves to adopt the H3 substitute for House Bill 4878. Clerk, would you please take the roll?
On the motion to adopt the H3 substitute, Chair VanderWall.
Yes.
Representatives Thompson,
Yes.
Meerman, Tisdale,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz, St. Germain,
Pass.
Bonac,
Yes.
Frisbie,
Yes.
Witsit, Carter,
Yes.
Whitwer,
Yes.
Neely,
Yes.
Hoskins,
Yes.
Foreman.
Yes.
Mr. Chair, you have 13 yeas, 0 nay, 1 pass. The motion prevails.
Thank you, Madam Clerk. Then we also had a H4 substitute that was handed to us by Representative Carter, and Representative Carter moves to adopt the H4 substitute. Would the clerk please take the roll?
On the motion to adopt the H4 substitute, Chair VanderWall,
No.
Representatives Thompson,
No.
Meerman, Tisdale,
No.
Bierlein,
No.
DeBoer,
No.
Preston,
No.
Schmaltz, St. Germain,
No.
Bonac,
No.
Frisbie,
No.
Witsit, Carter,
Yes.
Whitwer,
Yes.
Neely,
Yes.
Hoskins,
Yes.
Foreman.
Pass.
Mr. Chair, you have 4 yea, 9 nay, 1 pass. The motion does not prevail.
Thank you, Madam Clerk. Next, Representative DeBoer moves to report House Bill 4878 as substituted with recommendation the bill be referred to the Committee on Rules. Would the clerk please take the roll?
On the motion to refer as sub H3, Chair VanderWall,
Yes.
Representatives Thompson,
Yes.
Meerman, Tisdale,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz, St. Germain,
Pass.
Bonac,
Yes.
Frisbie,
Yes.
Witsit, Carter,
Pass.
Whitwer,
Yes.
Neely,
Pass.
Hoskins,
Yes.
Foreman.
Yes.
Mr. Chair, you have 11 yea, 0 nay, 3 pass. The motion prevails.
House Bill 4878 is referred to Committee on Rules. Next up, Representative Frisbie moves to report House Bill 4899 with recommendation the bill be referred to the Committee on Rules. I have a couple cards to read in before the clerk takes the roll. Not wishing to speak in support of it, Rich Ferran, HCAM. Not wishing to speak in support of the bill, Ashley Christian, Henry Ford. Not wishing to speak opposing the bill, Kaylee Beldwin, Michigan Nurses Association. With that, I lost my place. Oh, there we are. Next up, Representative Frisbie moves to report House Bill 4899 with recommendation the bill referred to the Committees on Rules. Would the clerk please take the roll?
On the motion to refer, Chair VanderWall,
Yes.
Representatives Thompson,
Yes.
Meerman, Tisdale,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz, St. Germain,
Yes.
Bonac,
Yes.
Frisbie,
Yes.
Witsit, Carter,
Yes.
Whitwer,
Yes.
Neely,
Yes.
Hoskins,
Pass.
Foreman.
Yes.
Mr. Chair, you have 13 yea, 0 nay, 1 pass. The motion prevails.
House Bill 4899 is referred to the Committee on Rules. Next up, Representative Thompson moves to report House Bill 4932 with recommendation the bill be referred to the Committee on Rules. We have two cards to read in. Not wishing to speak in support, Drew Bordsley, Michigan Retailers. Not wishing to speak in support, Eric Roth, Michigan Pharmacists. Would the clerk please take the roll?
On the motion to refer, Chair VanderWall,
Yes.
Representatives Thompson,
Yes.
Meerman, Tisdale,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz, St. Germain,
Yes.
Bonac,
Yes.
Frisbie,
Yes.
Witsit, Carter,
Yes.
Whitwer,
Yes.
Neely,
Yes.
Hoskins,
Yes.
Foreman.
Yes.
Mr. Chair, you have 14 yea, 0 nay, 0 pass. The motion prevails.
House Bill 4932 is referred to the Committee on Rules. Next up, Representative St. Germain moves to report House Bill 4934 with recommendation the bill referred to the Committee on Rules. Would the clerk please take the roll?
On the motion to refer, Chair VanderWall,
Yes.
Representatives Thompson,
Yes.
Meerman, Tisdale,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz, St. Germain,
Yes.
Bonac,
Yes.
Frisbie,
Yes.
Witsit, Carter,
Yes.
Whitwer,
Yes.
Neely,
Yes.
Hoskins,
Yes.
Foreman.
Yes.
Mr. Chair, you have 14 yeas, 0 nays, 0 pass. The motion prevails.
Thank you, Madam Clerk. Representative Beerline moves to excuse absent members. There being no objection, the motion prevails. There being no further business before the committee will stand adjourned.